The students from our Bashkir State Medical Universities, don't be afraid of us. We're not so dangerous, and we don't bite today. These nice girls especially. Please come forward to us. Yeah. We'll be happy to see you in front of us. So there'll be a translation in video in YouTube, and you'll be in the history if you sit in front. And we're starting our section on Young Investigation Award section. And first of all, so we are in jury. I think you see in the program. I think we will not lose the time. My name is Nауфаль Загидуллин, head of Department of Internal Medicine. There are my dear colleagues, and let's start our presentations. And first of all, so we have our good friend Amar Alamari, and he's online. He's from Turkey, from Istanbul, and if you're ready, the rest of us who please present, so you can in the same time copy their presentation. And if Amar Alamari is ready, please turn on his translation and his presentation. We're happy to see you, Amar. You're welcome to start the speech.
Everybody, thank you so much for this opportunity to be among you and for this great organization for this beautiful forum. I am Omar Al-Omari, an intern doctor from Hamidiyya International School of Medicine in the University of Health Sciences. I am here to present our new meta-analysis about the antithrombotic therapy utilization among patients with both cardiovascular diseases and the cerebral cavernosus malformation. Let's start my presentation. First of all, as we know, the cerebral cavernosus malformations are fragile vascular lesions in the brain. So in the last 10 years, the treatment of these lesions has improved too much. Like we have now gamma knife, so the patients can live longer. We control the bleeding rates of these patients.
However, sorry, Amar, can you make the full screen presentation?
Okay. So the patients getting the opportunity to live longer, we have the comorbidities with aging that will be a consequence of aging. Among these, cardiovascular comorbidities are in the top of the list. So the patients have to use antithrombotic agents. So there was always a dilemma between the cardiologist and the surgeons, like, can we use the antithrombotic in these patients or not? So they give, in the last 10 years, they give patients these medications and follow them for a long time. And they publish their results, like can we give them and they stay safe without any intracerebral hemorrhage? So our hypothesis was, in this meta-analysis, like thrombosis within the carcinoma can actually, if you give an antithrombosis to these patients, will this make the cavernoma bleed or not? So we searched the old databases. Since this is a systematic review and meta-analysis, we searched PubMed, Web Science, Base Scope, from their incipation to December 15th. Then we included paper that evaluating antithrombotic therapy, anticoagulants or antiplatelets in patients with cavernosus malformations, and we looked for the symptomatic intracerebral hemorrhage, bleeding rates, adjusted hazard ratio, and odds ratio. We gathered this information from the included studies. We used the random effect meta-analysis model to analyze these data all in one analysis. We assess the heterogeneity with the I-square and chi-square tests. and we use the R program to make these analyses. After the screening of the literature, we got 11 studies included with more than 5,000 patients. Sorry for noise. I'm in the hospital now. We have when check the safety of these medications, it figured out antithrombotic therapy showed no association with increased risk across all the 11 studies. So this outcome were constant among all the studies. Also, we even prove that we have a protective effect. That if you give them the antithrombotic agent, you will prevent formation of the thrombosis in the cavernous, and this will prevent the rupture of these malformations. Also, we have approved that patients on antithrombotics were significantly less likely to present with hemorrhagic stroke when compared to those with no antithrombotics. So here is our first plot. You here see the included studies in the analysis. Here you can see that we have a very low heterogeneity. So what's this plot telling us? That this side of the plot actually favors the antithrombotics, shows that we have a 3 times lesser risk compared to those who did not use the antithrombotics. And we have a very low heterogeneity rate. So this is a very good result. So after these results, we can make hypothesis that these drugs have a protective mechanism hypothesis. So how this mechanism works? First of all, normally if you don't give your patient this antithrombotic agents, they will have an intralesional thrombosis formation. So thrombosis will form and will go to the brain, and when it comes to inside this cavernous malformation, since it's as the blood, it will make a restriction there. This will increase intravenous pressure, and this will relate to rupture of this cavernous. So my conclusion there is antithrombotic therapy is safe in cavernous malformation patients. We did not observe any increased hemorrhage among these patients. Also, do not withhold the clinically indicated antithrombotics out of fear of these patients. As we know that until the 2020, it was contraindicated to use these things in patients with cavernous malformation, since the community treating these things like the stroke. It absolutely should not be treated like this. It's a very different type of vascular lesion, and as our results show that this is not the indication should be stopped, and the antithrombotic agent may actively stabilize the cavernous malformations by preventing the intralesional thrombosis. Thank you so much for your listening. If there's a question, I'm more than ready to answer.
Thank you very much. The very clear presentation. 0.3 odds rated is very high, first of all. And what? This is the meta-analysis. What antithrombotics? I mean, it's dual antithrombotic therapy, a triple, or the single. What do you mean by antithrombotic therapy in most of the cases?
Actually, most of the cases use the antiplatelets, not the anticoagulants. Antiplatelets, since actually the aspirin have the effect on the Rho kinase pathway in the vascular regions. So most of the studies used aspirin, but we have some studies used the direct anticoagulants, the new one, the oral direct anticoagulants. So there was a heterogeneity regarding the used agents. However, in this stage for the literature, we cannot do as a drug-based specific analysis. Here we can only do antithrombotics as a whole group. But in the future studies, we are right now writing this paper as paper text, and now we are the people to take agent or antiplatelets or anticoagulants in new trials. This is a very good question. Thank you, by the way.
Yeah, with the increase of number of drugs, the safety will be decreasing. Okay, thank you very much.
Yeah.
One short question. And do you have your own experience in treating such patients?
Actually, we have treated this patient, one patient in my in the institution that I'm working on. But in the initiation of the treatment, I was just a student, so I cannot say that I'm the one who treated the patient. But I'm doing the follow-up of this patient now. In he's a 57 years old male, and now he's in the third year follow-up, and still didn't face any problem regarding he aspirin and using the apixaban both together, and he's in his third year of follow-up, and we still didn't see any major problem.
Okay, thank you.
You're more than welcome. Thank you.
Thank you very much. And I should say, Amar was very right. Omar was very right. So 7 minutes for report, but he was just in exact time, and we continue.
Thank you so much.
Mm-hmm.
I'm sorry. So the next speaker is Bokovikov Ivan Fedorovich from Irkutsk, search for new circulating biomarkers for long-term prognosis of adverse outcomes in patients with prior myocardial infarction and type 2 diabetes mellitus.
It's our disclosure. And nowadays, presence of diabetes mellitus in patients with myocardial infarction significantly increases the incidence of complication and recurring cardiovascular events. In this regard, improving the accuracy of predicting recurrent ischemic events in the post-infarction period of the key importance for reducing cardiovascular mortality. And we hypothesized that new circulating biomarkers of cardiometabolic risk of patients with acute myocardial infarction may have predictive value for long-term survival of patients with diabetes. Our aim to evaluate the significance of new circulating biomarkers in the prognosis of long-term adverse outcome in patients with myocardial infarction and diabetes. Our decision, it was a prospective cohort multicentral study, a patient with STEMI diabetes admitted to regional vascular centers. We evaluated dates collection, laboratory dates, and we did observation period and endpoints. Criteria inclusions, non-inclusions, and exclusions are shown in this slide. Please allow me, don't read it. We analyzed a lot of patients, so 354 patients with STEMI, and finally we analyzed with STEMI and diabetes 112 patients for long-term outcomes. Our median follow-up is 517 days, and we had two main groups with and without reach the endpoint. As you can see, no difference in invasive and drugs treatment were recorded in the study groups. Group patients of STEMI and diabetes with acute heart failure more survive. Large cases of history of previous myocardial infarction, large cases of anterior myocardial infarction localization, and large cases with using insulin therapy. Also, according univariate Cox regression, history of dyslipidemias, left ventricular systolic dysfunction during hospitalization, number affect coronary arteries associated with adverse outcomes. What about circulating biomarkers? Three biomarkers, SST2, pentarcin 3, and resistin, more higher than in group without diabetes. But after univariate Cox regression analysis, we had three biomarkers who associated with adverse outcomes: SST2, resistin, and serum fractalkine. Also, we had unadjusted and adjusted multivariate Cox regression models and found these three biomarkers, SST2, resistin, and serum fractalkine, save their prognostic value. And finally, we constructed a basic univariate Cox proportional hazard regression model based on the scale GRACE, first generation. And we included these found circulating biomarkers and their combination. And finally, we had improvement in the prognostic accuracy of the GRACE scale by 54%. And finally, according to the result, a prospective multicenter cohort study, long-term cardiovascular events in these patients and diabetes were associated with the level of soluble SST2, resistin, and serum fractalkine. Also, addition of this combination with soluble SST2 and resistin to the GRACE first modification based risk model result in statistically significant improvement. But also other biomarkers, no dependent association of long-term cardiovascular events with NT-proBNP, pentraxin 3, and adrenomedulin. Thank you for your attention.
Okay, thank you very much. We have some questions. We discussed that. First of all, why do you took the blood serum after the STEMI? So normally, so usually, so it is taken before, because before the STEMI, because there is the damage, and it also could be different because it depends on the number of stented coronary arteries, and the increase of ST2 and some other biomarkers would be different. And the second question is strange that NT-proBNP didn't show the prognostic potential. Usually it shows it.
First question about
time of blood uptake.
But we take blood before during hospitalization, not after myocardial infarction. In day of hospitalization with STEMI.
Before or after STEMI? Before or after coronary intervention?
After.
That's I mean. Usually, it is more logical to take before the coronary intervention. Okay, it could be, but usually it is taken before. And about NT-proBNP, logically, NT-proBNP should correlate with MACEs, with the endpoints.
Maybe we had less patients in our study for NT-proBNP.
Thank you very much, and very nice presentation. Thank you for coming to Ufa.
And the next speaker is Asintsev Evgeny Sergeyevich, the problem of timely detection of valvular heart diseases. Please.
Dear colleagues and Presidium, today I'm glad to represent my research, the problem of timely detection valvular heart disease. So let's look, we declare no conflict of interest. Let's look on the numbers. So from 1990 to 2024, the specific aortic stenosis case increased in 2.7 global. So currently, it affects over 13.3 million people worldwide. So the burden is not only growing, it's shifting toward on an aging population, which makes screening even more critical. So why it's important? Because in many group of patients, the first representation of valvular heart disease is not a gradual decline, so but an acute emergency that needs a required hospitalization. So in this, this is the silent disease. The late diagnosis turns in a chronic condition into acute crisis. So our aim is to study the prevalence of acquired valvular heart disease in patients hospitalized in emergency cardiology department with primary diagnosis of coronary artery disease, decompensated heart failure, and cardiac arrhythmias. So this is what we wanted to see, how many of them had the valvular heart disease, which had never detected before. So we analyzed medical records and survey. Patients attended to a Camero clinic dispensary of cardiology. So from January to May 2025, we had total 2639 hospitalization. 17 patients were diagnosed with valvular heart disease. So we divided them into two groups. Group number 1 was newly diagnosed valvular heart disease, and group number 2 was known valvular heart disease. So this is the key finding. 55.7% were newly diagnosed valvular heart disease. So that means that more than a half of patients were missed in outpatient care, and they come to hospital not because of acute complication and not because of acute complication and not because their valvular heart disease was caught earlier. So why they were hospitalized? In group number 1, we saw significantly myocardial infarction and cardiac arrhythmias, suggests acute presentation as first valvular heart disease manifestation, and in group number 2, it is more decompensated of heart failure. This slide is critical. So if you look at the number, 64.5 had never been followed by a cardiologist, 66.7% had never undergone with transthoracal echocardiography, and even 15.4% had never been auscultated. So what about patient of group number 2 who know about valvular heart disease? This is more better, but still not good. 74.2% always underwent auscultation. 15% had the regular cardiologist visits, but only 45% visited cardiologists on every 2-3 years, and which is far too infrequent to progressive valvular heart disease. So let me summarize the conclusion. First, a high rate of newly diagnosed valvular heart disease among the hospitalized cardiology patients indicates systemic failure of outpatient detection. And second, poor outpatient adherence. 64.5% had never saw a cardiologist. 66.7% never had transthoracal echocardiography. So therefore, we strongly recommended regular transthoracal echocardiography screening and patient at risk population. It's elderly patient, those who had hypertension, coronary artery disease, and anyone with heart murmurs on auscultation. And we cannot afford to wait until the silent valve disease becomes more emergency situation. Thanks for attention.
Thank you for very interesting and crucial for our patient and public health report. My question would be about epidemiology. What type of valvular heart defect you most commonly see in your patients?
It's more an aortic stenosis, and the second was regurgitation on mitral valve.
Usually in our clinical practice, the statistics says yes. We see the same in our center.
Sorry.
We see the same statistics in our center as usual.
Thank you very much. And for the next presenter, I would suggest to change another person. And if Kolotsev Lyudmila Vladimirovna is listening to us, we ask you to make a report later. But now we would like to ask Asintsev Evgeny Sergeyevich. Sorry. Again, no, we wouldn't listen to you 2 times. Then we'll ask Kolotsev Lyudmila Vladimirovna. She's here from Belarus, online. So we are very happy to see your clinical report, clinical features of patient with myocardial infarction with non-obstructive coronary arteries. Please start the presentation.
Good afternoon, esteemed chairman and conference participants. Can you see my presentation well enough?
Not yet.
Not yet.
And now?
Just a minute.
Okay, thank you very much. I would like to present a study on a clinical profile of patients with MINOCA, myocardial infarction with non-obstructive coronary arteries. Is presentation seen well enough? I'm sorry?
Yes, now okay.
Yes. Okay, wonderful. Thank you very much. Myocardial infarction without significant coronary artery obstruction has been observed for decades in patients presenting with MI without a culprit artery. However, the term MINOCA was first introduced in 2013 by an Australian cardiologist, Beltrame, and not until 2017, European Cardiological Association recommended their criteria for MINOCA, which were the elevated levels of cardiac biomarkers, absent of stenosis in any of the epicardial arteries, I mean less than 50%, and absence of clinically alternate diagnosis. Given the absence of stenosis on angiography, MINOCA has been considered a benign disease, less associated with complications and death. However, the later investigations showed the opposite, that patients with MINOCA are even at higher risk than patients with MI-CAD, with coronary artery obstruction. In the later years, the demographic and epidemiological pattern of MINOCA was observed with a higher number of females, fewer traditional risk factors such as prevalence of hyperlipidemia, obesity, diabetes mellitus, and some unconventional associations such as AF, such as inflammatory diseases, and even mental health disorders. Our study aimed to characterize the clinical features of patients with MI with obstructive coronary artery disease. And so it was concentrated on patients with newly diagnosed acute MI who were admitted to Grodno State Cardiological Center for treatment from January 24 to December 25. The total number of patients was 196. The patients were divided into 2 groups according to their coronary artery involvement. Group 1 were 46 patients with MINOCA, while Group 2 were 150 patients with obstructive coronary artery disease. Exclusion criteria are presented below. All patients underwent laboratory, clinical, and instrumental investigations, including coronary angiography according to the Judkins method. Statistical analysis was performed using standard methods. And now let us move on to the clinical and anamnestic characteristics, which were the base of our research. And surprisingly, we found no difference in gender distribution between the 2 groups. The total number of male patients were around 72% without any difference. If now we move on to the age distribution, we found out that Minoka patients were slightly older with mean 62.7, while patients in MICD group were prone to be younger, the median of 58.1, which was statistically significant. Turning to patients' obesity distribution, we found out that patients with obstructive coronary artery disease were twice as predisposed to obesity in comparison with Minoka group, which also was statistically significant. When analyzing patients' other clinical characteristics, we found no difference in prevalence and stages of hypertension, as well as prevalence of arrhythmias such as AF, A-flutter. However, the localization of MI differed significantly. Surprisingly, Minoka patients had a more frequent involvement of the lateral wall of the left ventricle, while patients with obstructive disease, on the contrary, had higher occurrence of inferior and posterior wall MI. And another finding was higher rate of diabetes mellitus in patients with MI-CAD involvement, almost 3 times greater in MI-CAD group in comparison with Minoka. When we analyzed patients' complaints on admission, we found out that there were almost no difference in such standard common complaints such as external chest pain, dyspnea, fatigue, as well as such rare complaints as syncope, presyncope, nausea, and vomit. The only difference, which was statistically significant, was palpitations, which was more frequently experienced in Minoka group, which I suppose can partly be explained by microvascular involvement causing abnormal electrical activity, altering the ion channel function with elevation of arrhythmogenic potential. If we compare our results with the previous studies, the results seem to be quite contradictory. As we see in current literature data, Minoka has a strong female predisposition. However, in our study, the difference between males and females was not observed. Partly, I suppose it can be explained that the previous studies, they involved such conditions which now are called Minoka mimickers, such as Takotsubo syndrome or myocarditis, which have a stronger female predisposition, while in our study we excluded such patients. Therefore, insights given from this study, they have a clinical implication. And in conclusion, I would like to say that what were the main findings from our little research? We found that patients with Minoka were older, more frequently experienced palpitations, also less frequently suffered from obesity and DM, and had a higher prevalence of lateral wall MI. Of course, these results require further research, further insights into the careful development of diagnostic validation strategy and a tailored treatment strategy for Minoka patients who may not benefit from standard interventions like revascularization, but may require some other conservative treatment therapy. So thank you for your attention and valuable time today. If you have any questions, I will be glad to answer.
Thank you for your wonderful presentation. We have one question. You've told about palpitations. What arrhythmias were diagnosed in these patients?
Okay, thank you very much for your question. Usually it was sinus tachycardia. In some cases, it was atrial fibrillation or atrial arrhythmias. mainly. Of course, we observe such complications as ventricular tachycardia, ventricular fibrillation, but these cases, they were extremely rare and they accounted for less than 1% of all the cases.
Did you estimate the fraction flow reserve and some other parameters during the coronary angiography? Some tests, other tests with acetylcholine and so on in Minoka patients?
Okay, thank you very much for your question. Yes, it was the further part of our research. I presented only like a small part of it, but in the later stages, we analyzed the laboratory characteristics, echocardiographic characteristics, and coronary angiography, as well as acetylcholine test results. But this will be a subject of another talk, I guess.
Thank you very much.
Next speaker would be from Ufa, Moht Akhrasan, from monotherapy to triple therapy, quantifying the cumulative cardiovascular benefit on coronary heart failure with reduced ejection fraction treatment meta-analysis. Arsalan, you're welcome to present. Yes.
Presentation. 1 minute. 1 minute. Presentation.
So, good afternoon, everyone. My name is Muhammad Arslan from Bashkir State Medical University. I'm a fourth-year student, and I'll be telling you about my topic from monotherapy to triple therapy in heart failure reduced rejection fraction. So, there's no conflict of interest. So, let me tell you why this topic matters. As we know, heart failure reduced ejection fraction is increasingly worldwide, like around 26 million, and it's still going up. But if we look at the currently older therapy that we physicians give, is giving ACE inhibitors, ARB plus with beta blockers. But as it has been notified and been circulated that this combination is, after 3 years, putting the patients around the risk of 35% in death ratio. So, as the new guidelines suggest, we use ARNI, MRA, SGLT2 inhibitors. It would be beneficial. But as clinician, we should be knowing that how much is it benefiting, how much is the cumulative benefit of the patient, how much will it increase. So, our question became, what is the estimated cumulative reduction in cardiovascular death or heart failure hospitalization when all three foundational drugs are given in sequentially? So for our study, we used 4 databases, around 2,000 records, and with our strict inclusion criteria, we standard with 7 randomized control trials for it. As on the screen, you can see the table, the drug classes, the trials, and what are the drugs. For all these trials, the primary outcome was taken as cardiovascular death or heart failure hospitalization. So on the screen, you can see 3 forest plots. These 3 are 3 different drug classes separately. For ARNI, we can see hazard ratio of around 0.79. For MRA, hazard ratio is 0.67. And for SGLT2I inhibitors is around 0.73. This right now might not be of any understanding to you all. Here, this is our cumulative benefit calculation. This is our main theme. So because the drugs act through different distinction, they have different mechanism, so we can multiply their hazard ratios using the below formula. The HR cumulative The formula is there. So using the formula, we got around a cumulative hazard ratio of 0.39, which in turn gives us 61% of relative risk reduction. That is, number needed to treat is equal to 5 over 3 years. So 5 over 3 years is one of the best in cardiology. As we know, the statins group has around 40 over 3 years. BP drugs are around 50 over 3 years. So you can see the number needed to treat is widely less. So we get result as 0.31, which is 61% relative reduction. The number needed to treat is 5. So I will explain you why, how we are going to use it. So on the left, you can see the bar chart. On the blue bar, it is the standard old therapy, giving ACE inhibitors plus ARB plus beta blockers. So according to previous trials on this, it was reported that 35% of risk death hospitalization after this therapy for 3 years is 35. So what with our analysis, we got that we add MRA. After giving the baseline therapy, we add MRA, which reduces the risk down to 23.5%. And then afterwards, we add ARNI, which reduces it to 18.5%. And finally, when we add SGLT2 inhibitors, it will be reduced till 13.5. So you can see the old therapy was 35%, and when we add these three triple therapy, the reduction of risk is around 13.5. That is 21.5 less than older strategy. So in conclusion, just by giving these 3 drugs sequentially after the older therapy, we can reduce it by 21.5% of reduction in death, hospitalization, which in turn is very minimally good. The side effects are well known, manageable of these drugs. Severe adverse events leading to discontinuation were rare, reportedly, and therefore clinicians should start 3 foundational drug classes early, completely, and sequentially to full life-saving potential of modern guideline-directed medical therapy. But still, let me tell you what's the practical significance. So now we have around a specific estimate of how much we are benefiting. So no need to wait for months. We can add drugs stepwise, achieve most of it by giving them early. Future aspects, we are looking forward for our personalized randomized control trial for this combination therapy, and we hope Cardiology Center will cooperate. And as limitation is there only that for this cumulative benefit, there's no RCT yet. It's indirect evidence, but we hope from this evidence we can start our new RCT. Oh, thank you.
Thank you for your excellent presentation. And I have one question. To your point of view, what is your point of view? What side effects of these drugs could limit the assignment of these drugs to patients with heart failure?
So, as it was reported in the trials, the drugs like ARNI and MRA, they are practically, the side effects is hypotension. So, the patient who are suffering from kidney problems, kidney diseases, and we shouldn't be giving them this treatment. And SGLT2 inhibitors, we talk about that side effects. It's basically genital infections, especially in women, and some studies show it's also the hypotension. So mainly it's hypotension.
And about quadruple therapy, why didn't you use quadruple therapy? Why didn't you analyze quadruple therapy instead of triple? So for quadruple therapy, we are thinking of right now that we will use verticiguate as a new substance.
and these three foundational drugs.
Okay, thank you very much. So you're free, and do you have connection with Kazakhstan?
From Kazakhstan, Janagul Barnabayeva Bekbermbekova, biomarkers of cardiometabolic risk in patients with arterial hypertension and their association with coronary artery disease.
Good afternoon, respected professors, colleagues. Today I would like to present our study entitled Biomarkers of Cardiometabolic Risk in Patients with Arterial Hypertension and their Association with Coronary Artery Disease. Cardiovascular disease and arterial hypertension remain leading causes of morbidity and mortality worldwide, including in Europe and Central Asia. In Kazakhstan, particularly in Astana, cardiovascular disease and arterial hypertension demonstrate a persistent increase in newly diagnosed cases despite a gradual decline in mortality rates. These epidemiological trends indicate a growing population of patients with elevated residual cardiovascular risk, emphasizing the need for earlier and more personalized cardiovascular risk stratification approaches. However, regional evidence regarding cardiometabolic biomarkers, particularly lipoprotein little a, remains limited in Kazakhstan, highlighting the importance of population-specific studies. Therefore, improving early cardiovascular risk stratification remains clinically important. Given this epidemiological trends and the limited regional evidence on cardiometabolic biomarkers, we aim to evaluate early cardiometabolic biomarkers associated with coronary artery disease in patients with arterial hypertension. The study design and assessed parameters are presented in this slide. This cross-sectional pilot study included 62 patients with documented arterial hypertension with a mean age of 49 years. According to medical reports, patients were divided into two groups, patients with coronary artery disease and patients without coronary artery disease. We assessed anthropometric and cardiometabolic parameters, including body mass index, waist circumference, blood pressure, lipid profile, upper lipoproteins, high sensitivity selective protein, glucose, and lipoprotein little a. Statistical analysis was performed using the Mann-Whitney test. Regarding the results, the median lipoprotein little a level in the total group was 70 milligram per deciliter, with a maximum value reaching 409 milligram per deciliter. No statistically significant differences in lipoprotein little a levels were observed between patients with and without coronary artery disease. However, markedly elevated and highly variable lipoprotein little a levels were identified even in several patients without clinically documented coronary artery disease, suggesting possible latent or subclinical vascular risk. Next, a patient with coronary artery disease demonstrates as a less favorable cardiometabolic profile, including body mass index, high body mass index, waist circumference, and systolic blood pressure, consist with established mechanism of atherogenesis described in other cohort studies, previous cohort studies. No significant differences were observed in lipid profile, lipoproteins, glucose, and high sensitivity selective protein between the groups. These findings are consistent with established cardiometabolic risk patterns and mechanism of atherogenesis described in previous cohort studies. In conclusion, in patients with arterial hypertension, central obesity markers, particularly body mass index and waist circumference, very strongly associated with coronary artery disease. Although lipoprotein little a levels did not differ significantly between groups, markedly elevated values in several patients without clinical documented coronary disease may indicate early subclinical vascular risk. Further studies in larger cohorts are needed to clarify the prognostic role of lipoprotein a in hypertensive patients. This study is part of our cohort study in PhD dissertation, and now we have data of 96 patients, but we submitted abstract before, that's why we didn't change our presentation. Thank you.
Thank you for your report. My question would be about perspective. What is new done to cardiological knowledge? Because these factors are traditional, and are you planning to continue this research, and how? What are you going to bring new in this research?
Yes, we have not novelty. We try to analyze we try to find regional characteristics, but now we continue this result with this research, and we try to introduce this analysis, for example, lipoprotein a in our ongoing patient care, because this analysis is not free for our patients.
So maybe in next presentation you should highlight study of lipoprotein A, because this is a kind of new research, and things such as hip and wrist circumference is a kind of traditional already things which we already knew. And what about statistical data? We already have discussed it, and I think Nauфаль Шамилевич had comments about statistical.
Janagul, so hello. So we met recently in Astana in Kazakhstan in December. So you should balance the group. The group should be, to compare the parameters, you should balance the group. They should be balanced in age, gender, sex, and some other parameters. And to compare the parameters, you should do multi-factor analysis. Your head of the department knows how to do this. I think you should do this in your study. Okay, thank you.
У нас тоже следующий спикер онлайн, да? And let me introduce the next speaker, Байгожина Айжан Талгатовна, with the presentation Adherence to Optimal Medical Therapy in Patients with Chronic Heart Failure at the Primary Health Care Level. Are you here, Ayjan?
I'm here.
Okay. We see you.
Good day. Good day, dear professors, dear colleagues. I am pleased to present the result of our study assessing treatment adherence among patients with chronic heart failure in outpatient setting in Astana. Chronic heart failure.
Sorry, Ayjan, can you make the full screen?
Cases of Not here.
You have a small screen.
You have both the big screen and the small screen. Can you remove the small one and continue with the presentation screen?
Okay.
Okay, thank you.
Chronic heart failure remains one of the leading cases of morbidity and mortality worldwide. According to international data, up to 64 million people are affected globally. Prevalence increases significantly with the age. In Kazakhstan, the prevalence of chronic heart failure is around 4%. These figures highlight the importance of improving treatment adherence and long-term management in this patient population. Our study Um, mm, not, um, our study had three main objectives: to evaluate the clinical and epidemiological characteristics of chronic heart failure patients in Astana, to identify the main factors influencing treatment adherence, to develop practical recommendations aimed at improving adherence. Um, mm, the study population consists of chronic heart failure outpatients in Astana. The main subject of the study was treatment adherence and clinical course of chronic heart failure. We used questionnaire based assessment along with clinical examination dates, patients with all functional classes and all categories of ejection fraction were included. Follow-up assessments were conducted at 6, 12, and 24 weeks. To assess adherence, we used the validated MAS-8 questionnaire. These two help identify behavior, cognitive, and organization factors contributing to poor adherence. The main age in our cohort was 66.9. Men consist 67.9 of the sample. Comorbidities were common: atrial fibrillation, diabetes, anemia. More than half of the patients were retired and many had secondary or vocational education. Patients um, patients were categorized as heart failure, preserved ejection fraction, middle preserved ejection fraction, and reserved ejection fraction. We observed significant difference between groups. Reduced ejection fraction patients had higher heart rate and NT-proBNP levels. The 6-minute walk distance was lower, corresponding to NYHA class 3. Overall, 53.9 of the cohort had chronic heart failure reduced ejection fraction. Most patients research guidelines direct medical therapy, ACS inhibitors, ARNI 70%, beta blockers 63%, mineralocorticoid receptor antagonists 42%, CGLT inhibitors only 5%, and other medicines. Let us now turn the part of our analysis based on MAS-8 scoring. Height adherence 59.2%, moderate 23.8%, low 16.9%. Also, nearly 40% of patients demonstrated suboptimal adherence, a clinical significant concern. Education level showed a strong correlation with adherence. Highest education was seen in patients with high education. The lowest in those with secondary education. The difference was statistical significance. Key association revealed women showed significantly better adherence. Older age was also associated with higher adherence. Disease burden and marital status did not demonstrate statistical signification. Mean MAS-8 score were reduced ejection fraction 6.8, preserved ejection fraction 6.6, and middle ejection fraction 6.3. Adherence was slightly higher among reduced ejection fraction. Hospitalization, they showed a clear trend. High and moderate adherence group had 4 hospitalizations each. Low adherence patients had 15 hospitalizations. This indicates a markedly increased risk of decompensation in non-adherence patients. The main contributing factors at polypragmacy 27.6%, forgetfulness, complexity of remind, underestimating of disease severity, side effects, and most case where behavior and potently moderable. After target education investigation, high education increased from 59% to 75%, moderate adherence dropped from 24 to 10%, low adherence reduced to 50%. This change demonstrates the effective of structured adherence support strategies. Improved adherence was accompanied by a shot toward better functional classes. Further, patients remained in NIHA 3-4 classes, more patients moved to NIHA 1-2 classes. They reflect meaningful clinical improvement. All objective parameters improved significantly. 6 minutes test increased from 118 meters to 390 meters, and the proBNP and of ejection fraction percent. The majority of patients were men with heart failure reduced fraction. Adherence remains optimal and large population of patients. Female sex, older age, and high education correlate with better adherence. Low adherence increased hospitalization risk 6.9-fold. Improving adherence leads to improved symptoms, biomarkers, and functional status. Recommendation for patients. Care stages including education, self-monitoring, lifestyle modification, maintaining dirty logs, and active cooperative with physician. For physician, it is important to identify high risk group, particularly younger males with low education, and provide investigation support. That's all. Thank you for your attention.
Okay, thank you very much. Tell me, how did you estimate patients with heart failure of preserved ejection fraction, for example?
Sorry, can you repeat?
So you have patient with heart failure preserved and reduced ejection fraction. How did you estimate the preserved ejection fractions?
He comes here to polyclinic, and I made for him ФГБОУ.
Yeah, we do understand that he came to the polyclinic, but should be there some endothelial dysfunction should be estimated, and also NT-proBNP to estimate to differentiate between heart failure preserved and reduced ejection fraction. Okay, thank you very much. Thank you for participating our forum. And the next report is also from Kazakhstan, from Astana. Natalia Sergeyevna is here.
Here.
Very good. So you're welcome. From risk factors to prediction, interim results of study on coronary artery stenosis. You're welcome. Yeah, please present.
Good afternoon, dear organizers and participants of the conference. Please allow me to present the interim results of study about predictors of coronary artery stenosis in patients with coronary artery disease. In Kazakhstan, as in the rest of the world, the incidence of coronary heart disease is increasing. Percutaneous coronary intervention has improved treatment outcomes in these patients. However, stenosis still remains an important problem even with new generation drug-eluting stents and may lead to recurrent angina or acute coronary syndrome. At present, all predictors of stenosis are usually divided into 3 categories according to their causes. And the aim of our study was to optimize the early diagnosis of coronary artery stenosis in patients with coronary artery disease after coronary stenting. The objectives of our study were to identify clinical and laboratory predictors of restenosis, second, to develop a personalized predictive algorithm, and finally, to evaluate risk stratification models for early diagnosis of restenosis. The study included patients with coronary artery disease who underwent coronary artery stenting with follow-up coronary angiography at the Heart Center of the University Medical Center in Astana. At present, data from 392 patients were included in the analysis. The first group included patients with restenosis, and the second group included patients without restenosis in 1:1 ratio. We performed a comparative analysis of patient interview and examination data, ethnicity, anthropometric parameters, laboratory and instrumental findings, as well as coronary angiography and intraoperative parameters. The age of a patient ranged from 32 and 88 years with a mean age of 62 years. In both groups, most patients were between 50 and 70 years old. The ratio of men to women, as well as representative of a native nationality to Caucasian race, was 3:1. The most common comorbidities and risk factors of coronary artery disease were arterial hypertension, overweight and obesity, impaired glucose tolerance, and type 2 diabetes. Patients with a longer history of coronary artery disease were more prone to coronary artery stenosis. A history of myocardial infarction increased the risk of stenosis by 1.8 times. We compared body mass index, degree of obesity, and waist circumference between the study groups. A statistically significant difference was found only for waist circumference. As a result of comparing complete blood count parameters, biochemical markers, and coagulation profile data, a statistically significant difference was found between the groups in the parameters presented on the slide. According to echocardiography data, a statistically significant difference was in left ventricular ejection fraction was found between the groups. According to digital coronary angiography data, multivessel coronary artery disease was more common in patients with restenosis to compare it with patients without restenosis. A total of 608 stents were implanted in 392 patients. The mean number of implanted stents per patient was 1.8 in the restenosis group and 1.3 in control group. Next, binary logistic regression analysis was performed to estimate the probability of patient belonging to either the low risk or high risk restenosis group depending on sex. A total of 37 variables were included in the model. In men, the highest percentage of correctly predicted restenosis cases, 73%, was achieved at a cutoff value of 0.48. If a calculated probability of even occurrence was 0.48 or higher, the risk of coronary artery stenosis was considered higher than the probability of no restenosis. In women, when the predictor presented on the slide were included in the model, the cutoff value was 0.36. ROC curves were constructed to present the results of binary classification. Curves demonstrated good predictive performance for the model in both men and women. Using ROC curve analysis, cutoff value was determined at point with approximately equal sensitivity and specificity. The odds ratios identified by logistic regression analysis were conserved into a point-based scoring system. The minimum restenosis risk score was 0 points and the maximum score was 6 points. Next, male and female patients were divided into 7 groups with a step-of-line point. After that, the probability of restenosis was calculated for each group. In men, a score from 0 to 2 points was considered a low risk of restenosis, while 3 or more points indicated a high risk. In women, a score from 0 to 3 points was considered a low risk of restenosis, while 4 or more points indicated a high risk. Whereas the identified predictors and the developed risk scoring system will help identify patients with high risk of restenosis. Management of modifiable risk factors may help develop personalized treatment and rehabilitation program aimed at reducing the risk of coronary artery restenosis. Thank you very much for your attention and for the opportunity to present our study at this conference.
Thank you very much, Natalia. So we just also finished the study on coronary restenosis. I should say we have some other risk factors. First of all, the man, as in your study, it was increased LT, not ST, not LT, and also very strong predictor was the small diameter of stent. Please check this if you will further do this. The small diameter, the smaller is the diameter of the stent, the higher has, and this is according to the literature data, and the higher is the risk of coronary restenosis. And you do the study in the same artery, in the same location where the stent, or in the other artery?
Restenosis most commonly develop in the left arterial descending coronary artery. According for 52% of cases, the right coronary artery was.
Yes. I know. The question is in the same artery. Restenosis was in the same location. Stent, where was the stent, or in other location?
Yes, in the same.
In the same location. So we have a bit different data, but in somehow they're complete. But generally, you did more than we because you made the scale for the estimation of restenosis. So this is the very good example of the good statistical analysis. Thank you very much.
Thank you very much.
So we're going to the next speaker from St. Petersburg, Antusheva Maria Sergeyevna, QRS complex fragmentation, prognostic significance in patients with implanted defibrillator.
Презентация.
You're welcome.
Good afternoon, dear colleagues. My name is Maria Antusheva. Today I'm presenting my research, fragmentation of the QRS complex, prognostic significance in patients with implantable cardiovertebral defibrillator. Sudden cardiac death is a very challenging problem. Studies show that every year between 1.4 and 6.7 people per 100,000 die from sudden cardiac death. The risk of death is higher in men and elderly people. Even young adults can die from this, up to 3.7 per 100,000 per year. The ICD is the best tool to prevent the sudden death, but the ICD doesn't mean that the patients will live longer. Some patients still have been dying because of heart failure or other complications. So we need to find better markers for detecting patients at high risks of sudden cardiac death. So, what fragmented QRS is? It is when myocardium has scar, tissue, or fibrosis. This scar changes the electrical signals in the heart. Doctor can see FQRS and a simple ECG or on a Holter monitor. How do we recognize FQRS? If the QRS is narrow, less than 100 milliseconds, we see an extra air wave or notch in two leads that look at the same heart area. If the QRS is wide, more than 120 milliseconds, we see more than two air waves or notches in two or more leads. Why is fragmented QRS important? Many big studies have looked at FQRS. For example, the major two trial studies studies more than 1,000 patients with coronary artery diseases. The European Society of Cardiology guideline also mentions FQRS. A meta-analysis of 12 studies and large Finnish populations study all show that FQRS helps identify high-risk patients. However, some studies disagree. So my goal was to check if FQRS is really useful in my patients. The aim of my research was to see if FQRS can help find patients who need an ICD and who are at risk and dangerous of heart arrhythmias. How did I do study? First, I selected 300 patients with high risk of sudden death. All of them received in ICD 2020 for secondary prevention, meaning they already had a serious arrhythmia or cardiac arrest. Then I chose only those who had an ACG before the ICD was implanted. In the end, 110 patients were included. There was from 28 to 75 years. The average age was 57 years. What data did I collect? I looked at medical history, ACG, and Holter results before ICD and ICD programming data. I also called the patient of their family members to get follow-up information. The follow-up period was 56 months, that is almost 4 years. The main endpoint was death from any cause. Now, let me show you the results. Before ICD implantations, 30% of patients had history of ventricular tachycardia or VT. 7.3% had a history of sudden cardiac death. 51.8% had FQRS on their ACG. Telephone follow-up, I was able to research 71 patients. Among these 71 patients, 53 patients had no ICD therapy, 18 patients had a list on appropriate ICD shock. 4 patients received a heart transplant. 30 patients died from any cause. FQRS and history of VT. Among 57 patients with FQRS, 25 had VT in the past. Among 53 patients without FQRS, 19 had VT. The difference was statistically significant, so FQRS linked to a history of VT. Prediction deaths from any cause, I used ROC analysis. The IUC was 0938, that is very good. Sensitivity was 60.7%. And specificity was 8-9%. Let me summarize my findings. First, FQRS strongly predict all-cause death in high-risk sudden cardiac death patients. The IUC was 0938. Second, there is a clear relationship between FQRS and history of VT, and also with ICD therapy during follow-up. Third, FQRS can be an important marker on the ACG when doctor decide which patients should receive an ACD. First, we need more studies on FQRS to better predict arrhythmic events and to choose the best patients for ICD implantations. Thank you very much for your attention.
Thank you very much. We also completed the study on the FQRS. What do you think internally? What does the FQRS means? I mean, from the ventricle point of view.
I'm so sorry, my English is very good. Please, Russian.
I mean, the reason for the FQRS.
FQRS.
What's happened in the ventricles?
I don't understand you. Sorry.
Do you understand the FQRS?
Yeah, no,
Yes.
no, FQRS, yes.
Okay, very good. So, reason why? В чем причина развития FQRS?
Okay. I say from fibrosis and necrosis myocardic.
And probably inflammation, yeah?
Yes,
so
yes.
The myocarditis.
Yes.
Also,
the patients 16% in heart artery diseases, 25% dilatation cardiomyopathy, and 10% hypertrophic cardiomyopathy, and 5% arrhythmic long QT and arrhythmogenic dysplasians right ventricular cardiomyopathies.
Okay, thank you very much. And we also showed increase of sudden cardiac death among the FQRS. Okay, thank you very much. Mm-hmm.
Okay, and let me introduce the next speaker, Dasheva Ayana Semyonovna. Anatomical and functional determinants of myocardial ischemia in stable coronary artery disease, insights from quantitative CCTA and dynamic SPECT in patients with obstructive and non-obstructive coronary atherosclerosis, please.
Good afternoon, dear colleagues. Thank you for introducing me. I'd like to present our study. There are no conflict of interest. Coronary artery disease is the leading cause of cardiovascular mortality worldwide. A traditional assessment of traditional CAT assessment based on coronary stenosis. However, severity stenosis severity stenosis alone doesn't always mean myocardial ischemia. It's important in patients with non-obstructive coronary artery disease is a dependent clinical phenotype who have symptoms despite coronary atherosclerosis below 50%. Today we have two non-invasive methods of diagnostic. Coronary CT angiography allows us to assess not only coronary stenosis, but quantitative metrics of atherosclerotic plaques. Dynamic single photon emission computed tomography with CZT technology enables quantitative assessment of myocardial blood flow and myocardial fluid reserve. But there are knowledge gaps about association between quantitative plaque metrics in stable CAT and ischemia parameters by dynamic SPECT in patients with obstructive and non-obstructive coronary artery disease patients. The aim of our study to compare quantitative plaque metrics assessed by coronary CT angiography in patients with stable CAT and obstructive versus non-obstructive coronary atherosclerosis, and to evaluate their association with dynamic SPECT parameters, particularly myocardial blood flow and myocardial fluid reserve. The study included patients with stable CAT examined at Tomsk Cardiology Research Institute. All patients divided into two groups with non-obstructive and obstructive coronary artery disease by coronary CT angiography. All patients gated dynamic SPECT, and next step we analyzed all data. We analyzed plaque volume, particularly plaque components, using the ACT attenuation. By dynamic SPECT, we analyzed quantitative metrics, myocardial blood flow, stress and rest, and myocardial fluid reserve. And statistical analysis were performed. 60 patients with non-obstructive and 40 patients with obstructive coronary artery disease included in the study. Two groups were generally comparable in age and major cardiovascular risk factors, except type 2 diabetes mellitus. coronary CT angiography data was shown that patients with obstructive coronary artery disease had a significantly higher total plaque volume and a greater non-calcified plaque component. Low attenuation or high-risk plaques were more frequent in obstructive coronary artery disease cohort. However, a non-calcified plaque component was also detected in non-obstructive CAT cohort. Results by dynamic SPECT was showed that stress myocardial blood flow and myocardial flow reserve was significantly lower in patients with obstructive CAT. However, functional impairments were also detected in non-obstructive CAT patients, indicated that the absence of obstructive stenosis doesn't exclude ischemia or microvascular dysfunction. Anatomical functional association was showed that myocardial flow reserve was more strongly associated with plaque volume than with stenosis severity. The strongest association was observed with non-calcified components. Adding quantitative plaque metrics to the baseline model improved identification of reduced myocardial flow reserve. From a clinical point of view, a traditional approach based on stenosis has more limitation, but integrative approach allows more comprehensive ischemia phenotypes. On the slide, clinical case demonstrate patient with non-obstructive coronary artery disease. This patient has not scintigraphy impaired myocardial perfusion. However, reduced stress MBF and myocardial flow reserve were detected. These findings may indicate microvascular dysfunction and early functional impairment. Key conclusion of our study is next. In stable coronary artery disease, assessment of ischemia should be based not only on coronary stenosis, but also on quantitative plaque metrics and myocardial flow reserve. Thank you.
Diana, it's a really wonderful presentation. The two questions. So what's your impact in this study? And second, so this is some, I think it's from some grant from Russian Society, grant from Russian Scientific Foundation grant. And this study, your impact, okay, in this study.
I analyzed all patients and patients with obstructive coronary artery disease. This is my scientific groups in my dissertation. This is prospective study. Patient with non-obstructive CAT, this is a retrospective study, but all patients were analyzed by me.
Okay, you are a cardiologist or X-ray specialist?
No, I am a radiologist.
Radiologist. Mm-hmm. Okay, thank you very much. So we continue to the next person, scientist, young scientist, Polina Svarovskaya. So you're here, okay, very good. Muscle status characteristics in patients with chronic heart failure, camera.
Good afternoon, dear colleagues. Let me introduce the results of my research as a short report. So we declare no conflict of interest in our work. So, as we know, the patients with heart failure usually have a complicated comorbidity, which includes muscle status disorders such as sarcopenia or dyspnea. At the same time, the patients with heart failure and muscle status disorders can have specific cardiac remodeling. And it's noticeable that the patients with sarcopenia and heart failure usually have bad outcomes. So the objective was to assess the muscle status and its characteristics in patients with heart failure to conduct a comparative analysis of these patients. On the first step, our research included 58 patients with heart failure due to ischemic heart disease, except of acute cases, and arterial hypertension. So all the patients got through the short performance battery test to assess a skeletal muscle functionality. So the steps of short performance battery test, you can see on the slide, all the steps had the score. Also, the patients got through the 6 minutes walking test and instrumental diagnostic methods such as dynamometry, computed tomography, and echocardiography. Sarcopenia was diagnosed according to European Working Group on Sarcopenia, which means decreased muscle strength by dynamometry and decreased skeletal muscle index by computed tomography. Dynapenia was defined as decreased muscle strength only. So exclusion criteria you can see on this slide. At first, heart failure due to all cases except of ischemia, cardiomyopathy, heart valve disease, persistent atrial fibrillation, or atrial flutter. If the patient had heart valve surgery and anesis, this is exclusion criteria, and impossibility of performing the short performance battery test and 6-minute walking test. So sarcopenia was diagnosed in 22% of our patients and dynapenia in 17% of our patients. The middle age was about 66 years. Sarcopenia was mostly observed in men, they were younger, and dynapenia in women, and because of this group had lower height. Patients with dynapenia had slow muscle functionality. It means they had short performance battery score 6 points versus 8 in sarcopenia, less 6 minutes walking test distance, and decreased strength. All the points we compared with patients with sarcopenia on patients without muscle status disorders. Patients with sarcopenia had lower skeletal muscle index. It was expected because this is the criteria of this disease, and higher levels of NT-proBNP than the patients with dynapenia and the group without muscle status disorders. What about echocardiography? Patients with sarcopenia and dynapenia had left ventricular hypertrophy, increased left atrial volume index, and unfortunately, left ventricle ejection fraction and New York Heart Association classes were not statistically significant difference between the groups. So, conclusion. Patients with dynapenia. This group of patients were less functionally capable. As I said, they have less short performance battery test points, less distance of 6 minutes walking test, and decreased muscle strength. And patients with sarcopenia, they had a noticeable decreased skeletal muscle index and high NT-proBNP as the markers of system muscular, and maybe myocardial remodeling. Thank you for your attention.
We really discuss one thing because we usually know what is sarcopenia is. Could you please remind us what is dynapenia? Give criteria of it.
Dynapenia, it means only decreased muscle strength without decreased muscle quality, quantity, or skeletal muscle index. Yes.
Thank you. And our last speaker would be from Moscow, Sechenov University, Tachilovich Ilya Olegovich, with clinical utility of individualized NT-proBNP threshold calculator in the diagnosis of heart failure with preserved ejection fraction.
Good afternoon, dear colleagues. My name is Ilya Tachilovich. I'm a 6th-year student from Sechenov University, and I'm pleased to present my study about clinical utility of an individualized NT-proBNP threshold calculator in the diagnosis of heart failure with preserved ejection fraction. According to the European Society of Cardiology consensus, NT-proBNP is widely used for the early diagnosis of heart failure. However, its levels is very dependent on patient-related factors such as sex, age, renal function, body mass index, and atrial fibrillation. So, as you can see, these factors may either increase or decrease the NT-proBNP levels. And in routine clinical practice, it is not realistic for a physician to manually apply all these modifiers and percentages to calculate the NT-proBNP threshold. So this makes individualized threshold calculation difficult and not clinically relevant. Therefore, the main idea of our study was to develop a simple online tool that can calculate individualized NT-proBNP threshold automatically and can help us evaluate how this approach will help in clinical practice. This study included 153 patients with signs or symptoms of heart failure. For each patient, NT-proBNP threshold values were determined by two ways. First is standard fixed cut points from recommendations of Russian Cardiology Society of Cardiology. And second, we used the individualized cut points calculated with our calculator. After that, we compared the obtained cut points and reassessed the diagnosis of heart failure. At the first stage of our study, we developed a mathematical algorithm that can calculate the individualized threshold. After that, we implemented this algorithm to an online calculator. The user interface is designed to be simple and clinically practical. So in practice, the physician just enters the parameters of the patient and receives the threshold level of NT-proBNP. Now I would like to move on to the main results of our study. As you can see, we compared individualized thresholds with standard fixed cut points, and we did not observe a statistically significant difference in the overall cohort. But the subgroup analysis showed that the effect of individualized calculation was not uniform across all patients. In particular, significant differences were observed in men younger than 60 years, women aged 60 years and older, patients with reduced renal function, and obese patients. These findings suggest that individualized NT-proBNP threshold calculation may be especially relevant in patients whose biomarkers levels are strongly influenced by their age, sex, or renal function and obesity. This graph demonstrates the change of NT-proBNP threshold for each patient. So in the left side, you can see the standard fixed cut points, which are 125 and 365 for patients with atrial fibrillation. And in the right side of the graph, you can see individualized cut points, various individualized cut points. This graph shows that our calculator not only shifts the threshold in one direction, it increases it for some patients and decreases for others. So we developed the first Russian language online calculator for NT-proBNP threshold estimation in chronic heart failure diagnosis. Significant differences in threshold values were observed in women aged 80 years and older, and men aged less than 60 years, patients with reduced renal function, and patients with obesity. The use of this online calculator may reduce the risk of diagnostic errors in the patient groups and potentially improve clinical outcomes. So, the first and the most important limitation is lack of prospective validation. At this stage, we do not yet know the diagnostic value of this approach. So we see that not only as a limitation, but also as a field for future research. We are planning a prospective validation of our method. And overall, we understand that it is not a fully solution for the problem. The physician still needs to open an online website and manually enter all the patient parameters. But we see it as a small but important step in personalized approach for diagnosis of heart failure with preserved ejection fraction.
Thank you for your report. It's a really interesting topic. And my question would be about how you planning to use this cutoff data. Are you planning to maybe create a new classification for heart failure based on diets?
Yes, we're planning on firstly see if this approach is clinically relevant and will increase the diagnostic accuracy of NT-proBNP in a prospective study with golden standard as an expert echocardiography. And we also want to implement this calculation in scores like H2-FPF to improve the diagnostic accuracy of these scores also.
It would be very interesting to see publications and calculator. Good luck with it.
Thank you.
Okay, thank you. So let us finish this meeting. We want to say to every participant, thank you for your presentation, for your participation, and for your excellent reports. The results would be announced tomorrow. Yes. And we wish you good luck in your future new investigations.
So the results will be announced tomorrow at closing ceremony. So see you there and continue your research and good luck with it. And have a nice second day tomorrow.